Hello everyone, welcome back to my channel. Now today let us look at yet another very important topic, which is what are hemoglobin derivatives and hemoglobin variants. Okay. So first, what do we mean by hemoglobin derivatives and hemoglobin variants? What does these two different terms, hemoglobin derivatives and hemoglobin variants, mean? Okay, so let us look at the difference. Now, hemoglobin derivatives means when different ligands combine with heme or a change in oxidation state of the ion. Now, let us again come back to the basic structure of hemoglobin, which consists of four polypeptide chains, two alpha chains, two beta chains. So, these are the globin chains. Okay, and it has heme group attached to it. Okay, so it is a hemoglobin is a type of conjugated protein having a protein part which are globin polypeptide chains and a non-protein part which is the heme group. Okay. Now when different ligands bind to this heme group, okay, for example oxygen, we have seen in the previous lecture that oxygen binds to this heme group and that is how hemoglobin carries oxygen. Okay. So when oxygen, apart from oxygen, if let's say carbon monoxide binds or sulfur binds, okay, so when other ligands bind to this heme, it is known as hemoglobin derivatives. Okay, hemoglobin variants are, these are the defects in globin chain of hemoglobin. Okay, so variants, when you talk about, we are referring to the globin part, that is the alpha chains and the beta chains. When a defect occurs in these globin chains, then it is called hemoglobin variant defects. Okay, this is clinically what hemoglobinopathies are known as. Okay, so hemoglobinopathies means abnormal globin chain which is produced. Okay, for example, thalassemia, there is decreased production of normal chain. Okay, and sickle cell disorder, that is a defect in the globin chain. Okay, so that we will see in subsequent lectures. Okay, so clear between the difference between hemoglobin derivatives and hemoglobin variants. Okay, derivatives involves different ligands binding to the heme group. Variants involve a defect in the globin chain. Okay, now let us first see what is carboxyhemoglobin. Okay, carboxyhemoglobin is when carbon monoxide binds to hemoglobin. Okay, normally to this heme group oxygen binds, right? So that is oxyhemoglobin, and absence of oxygen water binds, so that becomes your deoxyhemoglobin. Now when carbon monoxide comes and binds to this heme group, it is known as carboxyhemoglobin. Okay, and this is dangerous. Why? First, that the affinity of carbon monoxide to this hemoglobin is 200 times more as compared to oxygen. Okay. So if given a choice for the hemoglobin to bind between carbon monoxide or oxygen, okay, choose between carbon monoxide or oxygen, the hemoglobin is going to choose the carbon monoxide. Why? Because it is 200 times affinity is more. Okay. Now the other problem is when one carbon monoxide binds to this heme group, it facilitates or favors the binding of oxygen to these other heme groups. Okay, to the other remaining three heme groups, oxygen molecule comes and binds. Okay, so binding of one carbon monoxide to the heme group favors binding of oxygen to other heme groups, other remaining three heme groups. Now, once this binding of oxygen with the other heme group takes place, these oxygen becomes unavailable for transport, unavailable to give to the tissues. In other words, they become trapped. Okay, so it becomes useless. So this is another problem which is there. First is that the hemoglobin has increased affinity for carbon monoxide, and second is on binding with carbon monoxide, the oxygen gets trapped with these heme groups. Okay, so carbon monoxide hemoglobin becomes unsuitable for oxygen transport. These are the two basic abnormalities which occur with carboxyhemoglobin. Okay. Now, if you look at the partial pressure of oxygen and hemoglobin saturation gives a false normal. Okay. Partial pressure of oxygen is the amount of partial pressure, the oxygen which is there in the blood. Okay, there is no problem with the partial pressure of oxygen. That might be normal. Okay, but and the hemoglobin saturation also is normal because hemoglobin is getting saturated with oxygen. Okay, but it is not the saturation, it is not correct. Okay, that is not being utilized because the oxygen which is binding to these three heme groups are not available for giving to the tissues. Okay, so even though the saturation is normal, yet it is false. Okay, so we measure the hemoglobin saturation by pulse oximeter. So even though the pulse oximeter may show a saturation of more than 90%, but that is of no point because that 90% oxygen which is binding to the hemoglobin is not available for tissues to be utilized. Similarly, when we take the blood gas analysis, we measure how much of partial pressure of oxygen is present in the blood. That again might be normal. Okay. Yeah. So coming to the causes. What are the causes which increase carbon monoxide levels? Okay. So carbon monoxide levels are seen excessively amongst mine workers, okay, who do a lot of mining, for example, coal mines, automobile exhaust, okay, that gives out carbon monoxides, smoking, okay, that increases the carbon monoxide levels. Also smoke inhalation in the fire, okay, when there is excessive burning somewhere, the chances of carbon monoxide poisoning is increased. So these are the various common causes which are there for carbon monoxide poisoning. Okay. So what are the clinical features? Excess of carbon monoxide, if it is there, or carbon monoxide poisoning is there, okay, that leads to headache, dizziness, pain abdomen, or nausea. And the oxygen dissociation curve shifts towards the left, okay, because the affinity of oxygen with hemoglobin is increased, so the oxygen dissociation curve shifts towards the left. Okay. What is the treatment? The treatment is to give 100% oxygen under high pressure so that the carbon monoxide is displaced from the hemoglobin and again it can be replaced with oxygen. So treatment is 100% oxygen under high pressure or hyperbaric oxygen. Okay. Now coming to the next one, which is met hemoglobin. Okay, so what is met hemoglobin? The met hemoglobin means, so when the iron present in the heme is oxidized from ferrous form to ferric form. Okay, so we know that again hemoglobin consists of heme and globin, and heme consists of iron at the center. Okay, and what is the valency of iron? It is a ferrous form, Fe plus 2. Now, if that Fe plus 2 undergoes oxidation, another loss of electron takes place and it becomes Fe plus 3. So, when this Fe plus 3 occurs, then it is known as met hemoglobin. Okay. Now, what is the problem? Whenever met hemoglobin formation occurs, this hemoglobin is not able to bind with oxygen. Okay. So, it cannot bind only. For carboxy hemoglobin that we had seen earlier, there was binding was there, but that binding was preserved. Okay, that binding was not broken. Here, in case of met hemoglobin, oxygen is not binding with heme. Okay, that is the problem. So, does our body normally produce met hemoglobin? Yes, our body does normally produce met hemoglobin, but we also have very fantastic defense mechanism. Okay, so we have NADH reductase, which convert it back to the ferrous form. Okay, so ferric form is converted back to ferrous form with the help of NADPH reductase, NADPH reductase, and glutathione reductase. So these are the enzymes which convert met hemoglobin back to normal hemoglobin. Okay, so when met hemoglobin occurs, how is it manifested? It manifests as cyanosis, okay, or bluish discoloration of skin and mucous membrane. Okay, that is cyanosis, when there is increased concentration of reduced hemoglobin. Okay. Now, what are the causes of met hemoglobin? It can be either congenital. Okay, it is seen in special type of hemoglobin which is called hemoglobin M. Okay, that we will see later what it is. And another, what are the acquired causes which we can acquire during a lifetime? Okay, in the presence of drugs like nitrates, aniline, certain enzyme deficiency conditions like G6PD deficiency. Okay, so these are few causes which results in met hemoglobin. Okay, so a congenital cause is hemoglobin M, and acquired causes are drugs, aniline dye, nitrates, enzyme deficiencies like G6PD. Okay, and this again causes the oxygen dissociation curve to shifts towards the left. Next, coming to what is self hemoglobin. Now, self hemoglobin is when hydrogen sulfide acts on the oxyhemoglobin. Okay, so heme binds with the sulfur. Okay, then it becomes a self hemoglobin. It also cannot transport oxygen, and because it cannot transport oxygen, oxygen is not binding with the hemoglobin. So just like met hemoglobin, here also it will be manifested as cyanosis. Okay, so because there is increased concentration of reduced hemoglobin or deoxyhemoglobin. So whenever there is increased concentration of deoxyhemoglobin, it manifests in the form of cyanosis or bluish discoloration of skin or mucous membrane. Okay. What are the causes? We have sulfur drugs, okay, and antibiotics which can cause sulfhemoglobin. Okay. Sulfhemoglobin cannot be converted to oxyhemoglobin, and it persists throughout the lifespan of the RBC, that is for 120 days. So this sulfhemoglobin is broken down along with the breakdown of the RBC. Now let us look at another important topic, which is hemoglobin variants. Okay. So hemoglobin variants, we have earlier seen that we are referring to defect in the globin chain, globin part of the hemoglobin. Okay, now hundreds of hemoglobin variant leads to various hemoglobinopathies. Okay, lots of hemoglobinopathies are there. So let us concentrate on few important ones. The variation can occur in alpha or beta chain of the hemoglobin. Okay, so we discussed that the hemoglobin variant is a defect in the globin chain. Okay, now globin chain can be alpha or beta globin chain. So the variation occurs in alpha or beta globin chain. Now important hemoglobinopathies are sickle cell anemia, thalassemia, it can be an alpha or beta thalassemia, hemoglobin E, hemoglobin C, hemoglobin D. Okay, so we'll look only at the important ones. Coming first to what is sickle cell hemoglobin, okay, or sickle cell anemia. Now sickle cell, it is the most common hemoglobinopathy worldwide. Okay. Now in this we have a genetic mutation. Now what is this mutation? The mutation, it's a point mutation which occurs at position 6 of beta chain of the hemoglobin. Okay, so what is the defect which is occurring? So hemoglobin is made up of, we have seen earlier, 2 alpha chains and 2 beta chain. Okay, so in sickle cell disorder, the defect is occurring in the beta chain. Okay, and in the polypeptide chain, beta chain, at position 6, normally there is the amino acid which is glutamic acid. Okay, normally glutamic acid is there, and instead of this glutamic acid, there comes another amino acid which is valine. Okay, so there is a change in the amino acid from glutamic acid to valine. So only single change results in this sickle cell hemoglobin. Okay. Now we all know that we have 2 beta chains. Okay. Now beta chains are synthesized from beta genes. Now we have 2 pair of genes. Okay. One gene is there in the on one chromosome. It is there in chromosome 11. Okay. So one chromosome 11 and another chromosome 11. Okay. One gene is there. Now if there is a defect in only one gene which is producing the beta chain, then it is called a heterozygous defect. If the defect involves in both genes are mutated, then it becomes a homozygous defect. Okay. Now why this is important? Because if it is a heterozygous defect, it becomes sickle cell trait. Okay. That means it is still compatible with normal life. Clinically, it is not very significant. The patient will not have significant problems and can lead a normal life. However, if both genes are defective, then it leads to homozygous condition or sickle cell anemia. So in this case, the patient has significant clinical abnormality and needs repeated blood transfusion also, okay, to maintain the normal hemoglobin. Okay, so that is why first we have to know what mutation is there. The mutation occurs at the beta globin chain. Okay, now if the mutation is occurring at the one gene producing beta globin chain, then it is called a heterozygous condition. If both genes producing beta globin chain, then it is called a homozygous condition. Okay, now what problem occurs? So when in case of sickle cell anemia, the problem occurs is this leads to formation of sticky patches on beta chain of deoxyhemoglobin. Okay, which sticky patches then leads to polymerization of sticky patches, and this ultimately leads to the sickling shape of the RBC. Hence the name sickle cell anemia. The shape of the RBC becomes sickle shape. Okay, this is normal discoid shape of the RBC, biconcave. This becomes sickle shape. Okay, just like a sickle. Now, why does the sickle shape occur? This occurs because of polymerization of the deoxyhemoglobin S. Okay. Now let us see. Now this is normal structure of hemoglobin. This is oxyhemoglobin. and under deoxy condition it becomes this shape. Okay. Now if you look over sickle cell, okay, now in case of sickle cell, again this is oxyhemoglobin S, whereas deoxyhemoglobin, it develops these sticky patches. Okay, so hemoglobin S, this is hemoglobin S, this is hemoglobin A, this is normal, this is abnormal, this is the mutated form of hemoglobin. So hemoglobin S under deoxy condition, it forms these sticky patches. Now the problem is, and if the deoxygenated condition, these sticky patches, they polymerize. Okay, they stick behind one another, and it leads to polymerization. This polymerization leads to sickling shape of the RBC. Okay, this is the sickling shape of the RBC. Now when the RBC becomes sickle shape, it can, it can cause obstruction to the flow of blood. Okay, and this can lead to, again, various clinical abnormalities. Okay, so this is the problem which is occurring. Now, how do we prevent this polymerization? Hemoglobin A, adult hemoglobin, or hemoglobin F prevents this polymerization. You can see over here, when there is increased concentration of hemoglobin A, okay, so deoxyhemoglobin, it binds over here. Okay, it can bind to the polymerized form of deoxyhemoglobin S, and it can prevent further binding of deoxyhemoglobin S. Okay, so it breaks this polymerization chain, and thus helps prevent polymerization of hemoglobin S and subsequent clinical features. Okay, so that is why a patient who has a trait form, okay, heterozygous form, that means one gene is defective, one gene is normal. So the gene which is normal, okay, which is producing hemoglobin A, but the gene which is defective produces hemoglobin S. Okay, so that is why in case of trait, we are also having hemoglobin A, which can prevent this polymerization and subsequent clinical features. Okay. And treatment also involves this increased hemoglobin A, and hemoglobin F prevents polymerization. Okay. So when blood transfusion is given, so upon blood transfusion, hemoglobin A concentration increases, and also this also prevents polymerization. Now hemoglobin S can bind and transport oxygen just like hemoglobin A. Now whenever there is sickled RBC, that leads to occlusion of blood vessels and cause various clinical complications. Okay, so this is what happens in sickle cell anemia. Basic biochemical defect. One mutation which is occurring, this mutation leads to formation of sticky patches, which leads to polymerization, which leads to sickle shape of the RBC, which leads to occlusion of blood vessels, okay, and leads to the organ defect. So how do we manage sickle cell anemia? Okay, first we need to diagnose it. How do we diagnose it? We can screen by sickling. If you look under the microscope, look at the RBC under microscope under deoxygenated condition. Okay, with the help of adding a reducing agent, then the blood smear or the RBCs, they appear sickle shaped. Okay, so this is the shape of the RBC which is seen under the microscope. Okay. However, to confirm this sickling test, we do hemoglobin electrophoresis. Okay, so first, what is electrophoresis? Electrophoresis, as the name suggests, electro means electricity. Phoresis is movement. Okay, so movement under electricity. Okay. Now what can move under electricity? Something which is already having a charge. Then only it will move under electricity, electric field. Okay. So hemoglobin has electric charge. Okay. So it moves under electric field. So when we apply electric field to hemoglobin, okay, normally, okay, let's say we apply sample over here, okay, and we apply an electric field. Okay. So positive to negative direction. So hemoglobin, the adult hemoglobin travels this much. Okay, let's say this is normal. A normal person has normal adult hemoglobin A only. He does not have hemoglobin S. So the hemoglobin moves so much distance, okay, based on the charge. Now when we have another sickle cell, the electrical condition becomes the electrical condition changes. Why it changes? Because glutamic acid is replaced by valine. Okay, so the electrical charge also on the hemoglobin changes. Now glutamic acid, okay, it is having a specific charge. So that charge also changes. Okay, it forms a slow moving, okay, it shows a slow moving hemoglobin S due to less electronegative following mutation of glutamic acid. Okay, so when we have a sickle cell trait, we have normal hemoglobin A. Okay, we have hemoglobin S which is separated out. Okay. So this is, we can see when you compare it with hemoglobin A which is normal, we can see one band which is over here. That means this band is corresponding to hemoglobin S. Oh sorry, hemoglobin A. So this band over here is hemoglobin A. But we also have another band which is hemoglobin S. Okay, which is further from the hemoglobin A. Now in case of sickle cell anemia, we do not have hemoglobin A. Okay, all the beta globin chains are mutated. So hemoglobin A is absent. So all of the hemoglobin is hemoglobin S. Okay, so the distance traveled is more. Okay, why? Because the electrical charge on the hemoglobin changes. Why this charge changes? Because glutamic acid is changed to a valine. Okay, so this is how we confirmed with the diagnosis of electrophoresis. Okay, what is electrophoresis? How exactly charge helps in separation? That we will see in a separate lecture. Okay, so for now, just remember that hemoglobin electrophoresis is movement of hemoglobin under electric field. Why? Because hemoglobin itself also is a charged particle. Okay, when there is change in charge in case of sickle cell anemia or hemoglobin S, that can be separated out and that can be diagnosed. Okay. So how do we manage that? Sickle cell anemia is managed with drugs also like hydroxyurea. So hydroxyurea, what it does is it increases hemoglobin F formation. Okay, so hemoglobin F, when there is increased formation of hemoglobin F, it has gamma chains. Remember, so hemoglobin F is made up of alpha 2 and gamma 2. Okay, so hemoglobin F, again, this also prevents polymerization of hemoglobin S. Okay, and decreased polymerization, that means decreased problems for the patient. Sickle cell anemia is again curative. We can do stem cell transplant. Okay, for that it is, and we can cure the condition. And if somebody is having sickle cell anemia and has not or cannot undergo a transplant, then they have to depend on blood transfusion. Okay, so this is how the management of sickle cell anemia takes place. Next, let us see what is thalassemia. Now, thalassemia, again, it's a type of hemoglobinopathy, that means affecting the globin chains of hemoglobin, in which there is decreased production of normal genes in an abnormal proportion. Okay. Now, sickle cell, the beta globin chain was abnormal. Why? Because mutation of the globin chain took place. Okay, beta globin chain. In thalassemia, the globin chains are not abnormal. There is no mutation taking place. So the globin chains are not abnormal. Mutation is taking place, but the globin chain production is decreased. So normally, if it was the globin chains which were produced were 100%, so instead of 100%, let's say 10% is getting produced. But this 10% which is getting produced are normal. It is same as that it was 100%. Okay. So normal hemoglobin A consists of 2 alpha globin chain and 2 beta globin chain. Now when there is reduced alpha globin chain production, normal reduced alpha globin chain, it is called alpha thalassemia. When there is reduced normal beta chain production, it is called beta thalassemia. Okay. Now what the problem occurs is there is imbalance between this globin chain. Okay. In case of alpha thalassemia, there is decreased alpha chains. In case of beta thalassemia, there is decreased beta chains. Okay, now we know alpha binds with beta. Okay, so there is decreased production of beta globin chain in case of beta thalassemia. So there is excess of alpha chain. So this alpha chain needs to bind with something. Okay, what? That we will see. Okay, so beta thalassemia is more common as compared to alpha thalassemia. Now let us look at beta thalassemia. Now beta thalassemia also occurs because of point mutation in the beta globin gene. Okay. Now this point mutation in this beta globin gene leads to decreased production of beta chains. Okay. Or it can lead to absent production of beta chain. Okay. Now the mutation can lead to two problems. Okay. One is production of beta globin chain is decreased. Okay. Initially, let's say it was 100%, now it has become 20%. So the production has decreased. or the production can be absolutely 0%. Okay, no beta globin chains are getting produced. Okay, so two problems can occur. Okay, if one beta globin chain is affected, it is called minor condition or beta thalassemia trait. If both it is affected, it is called beta thalassemia major or intermedia. Okay, so let us see this classification. Normal, in case of normal condition, we have homozygous beta. We have two beta genes. Okay, as we have seen earlier, both genes are functioning normally. Okay, now thalassemia minor. Okay, beta thalassemia minor. Now in this case, we have one gene. We can have one gene which is not producing anything, no beta globin chains, but the second is producing. Okay, plus means it is producing. It is decreased. See, decreased production of beta chain is beta plus. So beta plus here means decreased production but of normal beta chains. Now we have another condition called thalassemia intermedia. Now what is this? It's a homozygous condition. Homozygous means both genes are affected. Okay, so this was thalassemia minor was heterozygous condition. One gene was affected. Okay, one gene was normal, one gene was one gene was affected. Okay. Now the one gene, just coming back to this thalassemia minor. Okay. Now thalassemia minor can be, I told you, it's a heterozygous condition. Okay, so one gene is affected. Now one gene which is affected, that affected gene can be beta 0, that means no beta genes are getting produced, or that one gene which is affected, it can be beta plus, that means it is producing some amount of beta globin chains. Okay, but the other gene which is there, that is normal. Okay, now in case of intermedia, both genes are affected. Okay, however, both genes will mildly produce beta chains. Okay, now the last one is, the problematic one is thalassemia major. Now this also is a homozygous condition. Okay, that means both genes are affected. Now this can be again homozygous beta 0, both conditions are affected. Okay, so in both genes, zero production of beta globin genes are taking place, or it can be homozygous beta plus, a very significant amount of defect is there, where only, let's say, only 5% or 10% of beta globin genes are affected. Okay, so from this classification, there are two things that you should remember. One is whether it is a homozygous condition or a heterozygous condition. If it's a homozygous condition, that means both genes are affected. Okay, heterozygous, one gene is affected. Okay. Now second question you must ask, if the gene which is affected, whether it is beta 0 or beta plus. If it is beta 0, that means zero production of beta globin chains. If it is beta plus, then decreased production. Okay, these are the two things that you should know, and based on these two things, this beta thalassemia syndromes is classified. Okay, now I told you earlier that problem occurs. What is the problem? We are having, it is beta thalassemia, so beta chains are less or absent. So the problem occurs with alpha chains. Now there is excess of alpha chains. Now what will these excess of alpha chains do? Okay. Now this excess of alpha chain, either it can combine with gamma chains. When it combines with gamma chains, we have alpha 2, gamma 2. So results in the formation of hemoglobin, or the excess alpha chain combines with delta chains, alpha 2, delta 2, and it forms increased concentration of hemoglobin A2. Now this hemoglobin F and hemoglobin A2, their concentration which is increased, this we see in electrophoresis. Okay, this will pick up in electrophoresis test. Okay, now the other problem is still the alpha chains are excess. Now these alpha chains which are excess, they precipitate, okay, because they have nothing to bind to, so they precipitate inside the RBC and they cause hemolysis, breakdown of the RBC, and hemoglobin levels are low and results in various the clinical features of thalassemia. Okay. So coming to the management of thalassemia. So first the investigation. Just like sickle cell, hemoglobin electrophoresis, here also it is used. Okay, just like in case of sickle cell anemia. Now in case of hemoglobin electrophoresis, see this is normal. We have taken the point of origin over here, we apply sample over here, and hemoglobin, let's say adult hemoglobin moves till here. Okay, that is hemoglobin A. This is normal hemoglobin. Okay. Now hemoglobin F, okay, we have less than 1% of hemoglobin F, but this is the area where hemoglobin F till where it is moves. Okay. Similarly, hemoglobin A2, okay, we have roughly 2 to 3% of hemoglobin A2, so this is where the hemoglobin A2 moves. This is normal. Okay. Now, why the difference in distance traveled between hemoglobin A2, hemoglobin F, and hemoglobin A? Because the distance traveled depends upon the charge. Okay. So charge depends upon the how much of what is the globin chain makeup. Okay. So this is what is normal. Then in case of beta thalassemia trait, what happens is hemoglobin A2 levels are increased. Okay, hemoglobin A2 levels are increased and hemoglobin hemoglobin A levels are decreased. Okay, so that is beta thalassemia trait. Okay, so why this happens? See, this is beta thalassemia trait or thalassemia minor. Now what has happened? This is a heterozygous condition. Okay, so the first question we discussed was to find out whether it is heterozygous or homozygous. So this is a heterozygous condition, meaning one gene is defective, one gene is normal. So the normal gene is producing hemoglobin A, but it is not producing as a normal person, because in this normal person hemoglobin A was produced by two genes, okay, two beta globin genes, but here one gene is defective, so the hemoglobin A produced is decreased. Okay, so when there is excess of alpha chains, these excess of alpha chains, they form increased hemoglobin A2. Okay, so hemoglobin A2, it is increased, and one hemoglobin A2 is in between the levels of 4 to 8%. Okay, and it might be the only abnormality which is seen in case of anemic patient. Then it is diagnosed as beta thalassemia minor. Okay, so in other words, how do we diagnose beta thalassemia minor? Any patient who is anemic on hemoglobin electrophoresis, if the hemoglobin A2 levels are between 4 to 8%, it is diagnosed as having beta thalassemia minor unless proven otherwise. Okay, it is a very straightforward diagnosis. Anyone who is anemic and has hemoglobin A2 levels between 4 to 8% on hemoglobin electrophoresis is known to have beta thalassemia trait unless proven otherwise. Okay. Okay, now why hemoglobin A2 increased? Because we have excess of alpha chain which combines with delta chains to form as increased hemoglobin A2. Now let's see beta thalassemia major. Now beta thalassemia major is, in the classification you can see over here, beta thalassemia major, it's a homozygous condition. Okay, both conditions are homozygous. That means both genes are defective. If both genes are defective, we are not going to get normal hemoglobin, which is hemoglobin A. Okay, so here you can see over here hemoglobin A is very less, it's less than 5%. Okay, normally it is more than 96%, so this is less than 5%. Okay, so what happens with this excess of alpha chain? Now this excess of alpha chain forms hemoglobin F, so this hemoglobin F percentage increases to more than 90%. Okay, and hemoglobin A2 also is increased around 4 to 10%. So beta thalassemia major, we have increased hemoglobin A2 and significantly increased hemoglobin F. Beta thalassemia trait, we have increased hemoglobin A2 and slightly low or below normal hemoglobin A. Okay, or sometimes hemoglobin A can be normal also, not a problem. Okay, so this is how we diagnose beta thalassemia. What is the management? In case of beta thalassemia minor, it does not require any significant treatment. It is compatible with life. No significant treatment is required. In case of beta thalassemia major, these patients, they require repeated blood transfusion to maintain their hemoglobin levels, and also, as they can be offered as stem cell transplant, which is curative for beta thalassemia. Okay. So I hope these hemoglobinopathies, hemoglobin variants, and hemoglobin derivatives are clear. You have understood. Okay. Thank you very much.